Assalamu alaikum, this is Shamama, and today my topic of discussion is the atrial fibrillation, and more precisely we'll discuss the causes of atrial fibrillation, how we can diagnose a patient of atrial fibrillation, and how we will manage that patient. So these are the 3 points which I'm going to discuss in today's video. I hope they will help you out. So starting with the causes of atrial fibrillation. So, for understanding the causes of atrial fibrillation, I have made a mnemonic that there is, of course, since it's atrial fibrillation and it's a part of heart atria, so I have made a mnemonic here to memorize its causes, and these causes which help us in the diagnosis of the patient. Okay, now these causes mnemonic is that heart and lungs, these are two best friends, or these are two friends which are damaged by, of course, stress, and after this damage they become extremist. So heart and lungs, these are two friends who become damaged by some stressful conditions and they become extremists. So just remembering this mnemonic, we can remember all the causes of atrial fibrillation starting from the heart. Now in heart, what kind of problems can be there? They can be ischemic heart disease, or any coronary artery disease, myocardial infarction, any structural heart disease, particularly mitral valve disease, and more specifically in stenosis atrial fibrillation occurs. Then in lungs problems, even hypertension can be the cause of atrial fibrillation. In lungs, what can occur in the lung? Pulmonary embolism in the lungs, or COPD can occur within the lungs. So these can contribute to atrial fibrillation. And now stress are very simple. We commonly know what are the common stresses: infection, any malignancy, any condition in which our adrenergic system is aggravated, like hyperadrenergic states. Now if you can recall any hyperadrenergic state, it can be pheochromocytoma, for instance, cytoma, or if a patient is taking some drugs that are stimulant, and we know stimulant drugs are cocaine, amphetamine, alcohol abuse, it is a stress. So all these stressful conditions, they have damaged these heart and lungs. They can be contributor. And extremist, how did he start to perform extremes of activity or lifestyle? Either he undergoes sedentary lifestyle, extreme sedentary lifestyle, or start doing excessive exercise. So all these causes, they are the reason why atrial fibrillation can occur. Now remembering these causes is very important, as it will help us to pick many important points from the history as the patient comes to us. This is a very important clinical correlate. Now we'll talk about a second point of discussion, that is how we can diagnose a patient of atrial fibrillation. Now, in diagnosis, very important points. We have a way how to diagnose a patient. Starting from first, a complete history of the patient is required. Now, in history, we can ask him that, okay, you have any lungs disease or any disease of the heart, or any history of some structural heart disease like mitral valve stenosis, or do you have any current infection or any malignancy? So these all points of history we can ask from the patient, which are contributing to the diagnosis. Second, we can also ask him about his lifestyle, that do you do excessive exercise, or you excessively sedentary in your lifestyle? So all these points, they will help us moving towards the diagnosis. So a complete history is very important. Second, we go for examination of the patient. Third, that is very important, and that is the gold standard test. So I'm writing here this ECG. It is a very important MCQ that comes us, that which is a gold standard test for diagnosing atrial fibrillation, that is ECG. Now what we will see in ECG, I've already discussed with you in the previous video, that what we will see in ECG is the problem, which problems we are facing. Let me just discuss some problems. In atrial fibrillation, we are facing problem in the atria, in the ventricles. Now, because of atria, as they are contracting rapidly but in ineffective and uncoordinated manner, so only some baseline oscillations of p waves will be present. These are sawtooth p waves or baseline oscillations of the p wave. They will be seen on the atria. I'll write here, these are baseline oscillations seen and in the ventricles. Now we know that ventricle we have irregular impulse. So what you will see is main finding on the ECG will be irregular impulse. Now how we can diagnose this irregular impulse means that it is having an irregular impulse. Irregular means abnormal rhythm. How you see the rhythm? That we find out the intervals between two R waves. Somewhere it is high, somewhere it is very low. So this is the interval between two R waves. So here you can see that there is an abnormal rhythm of the heart, plus the pulse or the ECG that is seen here is irregularly, means at irregular intervals. The RR intervals means the heart rate is changing at an irregular interval. So this is the irregular impulse that is seen on ECG. In the P waves, we see these baseline oscillations, and these are the RR intervals on the ECG. So these are the changes which are seen on ECG. Fourth test which will undergo is echocardiogram. Why we are undergoing this echocardiogram? Because we know one of its cause is structural heart disease or mitral valve stenosis. So to see it or to rule out that whether this atrial fibrillation is because of the mitral valve stenosis or any problem on the mitral valve, we go for echocardiogram. In echocardiogram of the left atrium, we can identify this problem. And fifth, we know that it is associated with hyperthyroid. As we know, in hyperthyroidism our metabolism is increased, so it is associated with hyperthyroidism. So that's why we undergo thyroid function test. Now why are we undergoing thyroid function test? That we'll see that if the patient is having elevated T3 and T4 levels and low TSH level, then we can say that this atrial fibrillation is because of the thyrotoxicosis. Now moving on, I hope diagnosis is clear now. Moving on, that how we will manage the patient, what is the treatment of atrial fibrillation. So to understand the treatment in a very clear way or in a very good way, you should actually first of all keep in your mind that what are the problems that the patient is facing. Okay, so first of all, before the treatment, I will discuss that what are the problem that the patient is facing. The main problems that the patient is facing is, first of all, because of pooling of blood within the atria, thromboembolism can occur and patient can have ischemic stroke or etc. So the main problem is thromboembolism, means clotting is there, so we have to go for anticoagulation in this problem. Second problem is in the ventricles. Now ventricles, they are having very high rate abnormal rhythm. So in the ventricle the rate is abnormal, the rhythm is abnormal, the rate is as high as 75 to 175 beats per minute, which is very high. Normal is just 60 to 100 beats per minute is normal heart rate. Okay, rhythm is abnormal. The third problem is this embolus formation is done. We've talked about the ventricles, and these are the problems which now we have to solve in the patient. And of course the main problem is that there is ectopic firing occurring within the patient, so we have to also manage it out, which is the main root of all the problem. So moving forward, talking about the treatment. Now, first of all, we'll solve the major problem of thromboembolism, rate abnormality, rhythm abnormality, ectopic firing. First, let's see that patient has an abnormal heart rate. What we will do to maintain the heart rate is that we have to maintain a target of less than 110 beats per minute. Okay, now for that purpose we will of course give some drugs which will reduce the heart rate. Now for that purpose we use the first line drug therapy are beta blockers. We prefer beta blockers as it is also an MCQ that what is the first line therapy in atrial fibrillation, that is beta blockers. Beta blockers are given, and if the patient is having any problem with beta blockers or he's not responding to beta blockers, then second we can go for calcium channel blockers. Now basically, first of all we should know that how the beta blockers they reduce the rate. What do beta blockers do? We know that the main function of beta blocker is that they inhibit the beta cells, and our whole heart is made up of beta cells. So when the activity of our heart tissue is reduced, first of course the rate will reduce, and second important point is that since ectopic tissue is because of the normal heart tissue, so when heart cells are depressed, as a result the ectopic firing will also reduce. This is the action of beta blockers. Moving on to the calcium channel blockers, what do is that they reduce the AV nodal conduction. As a result, the impulse moving from AV node to the ventricles is less, and leading to reduced heart rate, which is our main goal. Now if suppose a patient came to us has left ventricle systolic dysfunction, in that case to maintain the heart rate, a drug of choice will be metoprolol succinate. Now why we are giving this drug? What is so main role of this drug that we are using it as the drug of choice for this condition is very important. This drug has very important role. What is this drug? First of all you should know it is a beta blocker. What it will do is, first of all, of course, its action of this drug is that it inhibit the epinephrine action on the beta cells, resulting in reduction of the heart rate, and automatically the rhythm is also reduced. Second important role is of this metoprolol succinate is that it improve this left ventricle systolic dysfunction, in which the main problem is that systolic function is reduced, leading to reduced ejection fraction. So what this metoprolol succinate does is that since it's reducing the heart rate, now when heart rate is reduced, the ventricles are now getting increased time for filling. So ventricle filling is increased, and when ventricle filling is increased, then it lead to increased blood coming to the ventricles, and as a result increased amount of blood that is ejected from the ventricle with each contraction, that is the stroke volume is increased, and resultantly ejection fraction, that is the fraction of blood that is ejected from each ventricle with each contraction, that is increased, and resulting cardiac output is increased, and all these they solve the problem of left ventricle systolic dysfunction. Third important role of this metoprolol succinate is that it reduces the ventricular remodeling, as a result reducing the damage in the patient. So this was the main role of this drug, why we prefer this drug for patients with atrial fibrillation along with left ventricle systolic dysfunction. Fine. So we briefly, to control the rate, we have three options: beta blockers as first line therapy, calcium channel blockers if a patient doesn't respond to the beta blockers, and if it's superimposed with left ventricle systolic dysfunction, then metoprolol succinate, a beta blocker, is the drug of choice. Fine. Now moving on to our second problem, that is the abnormality of the rhythm. So we have to maintain the rhythm. For maintaining the rhythm, what we do is that the first therapy is cardioversion. Now the question will arise in your mind that what is this cardioversion? Okay, cardioversion is a procedure in which shock waves are given to the heart in synchrony with the QRS waves. Now, during the QRS waves, we give the shock waves. What these shock waves will do, they will terminate all the abnormal rhythm of the heart, like ventricular tachycardia, supraventricular tachycardia. So these all will be terminated, and the heart will return to the normal sinus rhythm through this cardioversion. Very important point. We didn't give this cardioversion during the T waves because it will lead to ventricular fibrillation. Okay, now there are two types of cardioversion. Cardioversion are of two types. First is the electrical cardioversion, second is the pharmacological cardioversion. Now, what is electrical cardioversion? Electrical cardioversion, the same which I repeated, that shock waves are given in this process and normal sinus rhythm of the patient is maintained. Now, out of these two, electrical cardioversion is preferred in patient, and it is so basically this electrical cardioversion is preferred out of two. Plus, if a patient comes with atrial fibrillation and is hemodynamically unstable, then we go first for electrical cardioversion. Then electrical cardioversion is given to the patient immediately. I'll write here immediately is very important to save the life of the patient. We go for immediate electrical cardioversion. Fine. Now there is a problem. This electrical cardioversion, it has a problem that it increases the risk of embolus formation. So when we have to give cardioversion to a person, what we'll do is that we give anticoagulation. Now, why anticoagulation? To reduce the risk of thrombus and as a result embolus formation. So what we'll do is that we give anticoagulants to the patient 4 weeks. Now, how we'll give anticoagulants? 4 weeks before starting cardioversion and 3 months after complete cardioversion is performed. 3 months after complete cardioversion, we continue these anticoagulants. Now there is an exception that if we don't want to wait for this long time to give anticoagulants, then we perform transesophageal echocardiogram TEE of left atrium and see if thrombus is present or not. Now, after performing this procedure, if thrombus is not present, then we can only give IV heparin to the patient and perform cardioversion. Then we can give IV heparin to the patient and cardioversion can be performed within first 24 hours. And after complete cardioversion, we'll go for the 3 to 4 weeks of anticoagulation therapy to avoid any thrombus or embolus formation. Okay, now coming on to the pharmacological cardioversion. Now, what are the options we have in pharmacological cardioversion? Of course, first are the beta blockers, second drugs are the antiarrhythmics. Antiarrhythmic drugs. Now I'll discuss these antiarrhythmics on the next page. Just a second. Talking about these antiarrhythmics, we have two options of these antiarrhythmic drugs. One is IV Fecainide, which is class 1C antiarrhythmic drug. Now, these IV Fecainide is given in those conditions when the patient has no structural heart disease and he is stable. No structural heart disease and the patient is stable, then we'll go for IV Fecainide. But what if the patient has some structural heart disease or ischemic heart disease, then in that case we go for IV amiodarone. IV amiodarone is given in that condition. Fine. So these are the antiarrhythmic drugs. Now, if the patient is not responding, very very important point, that our alternative therapy to it is catheter ablation. When we'll do this catheter ablation, that when it is indicated that if the patient is not responding to both the cardioversion, if the patient is not responding to both the pharmacological as well as electrical cardioversion, then we'll go for catheter ablation. Now what we'll do in this catheter ablation procedure, we ablate the heart tissue that is causing ectopic firing, and as a result return the rhythm back to normal sinus rhythm. Fine. So what we'll do is that we disconnect electrically pulmonary veins from the left atrium. Why pulmonary veins? Because the muscle tissue around them is the main site and the most common site and the first site where this will develop ectopic foci. Fine. Catheter ablation is performed, and at the last, when all the strategies fail and the patient is in severe state, poorly controlled case, in that case the management strategy is that we go for pace and ablate therapy. Now what is this pace and ablate therapy? It is very important in to understand that pace and ablate, we implant a permanent pacemaker in that patient, plus we deliberately ablate some of the part of the heart tissue. So we deliberately induce AV nodal block, complete AV nodal block. This is the pace and ablate therapy, that we implant a permanent pacemaker in the patient and we deliberately induce complete AV nodal block, as it is a last strategy in those patients who are in severe state and who are poorly controlled. Fine. Now talking about that, how we'll go for anticoagulation, what are the strategies and how we maintain anticoagulation. For that we have two options. One is warfarin, and warfarin is INR 2.0 to 3.0. Now there is a problem when we give warfarin in patients who have some structural heart disease. So you can say its indication is for patients who have structural heart disease. Fine. Now we have a problem in giving this warfarin. Now what is that problem? That this warfarin has a side effect, that it has increased risk of bleeding. So of course we should know any drug that can reverse the action of warfarin. So for that purpose, the reversal agents of warfarin, very important to know. What are the reversal agents of warfarin? So the reversal agents of warfarin are, we can give vitamin K to the patient, we can give fresh frozen plasma, or we can give clotting factors, which is prothrombin complex concentrate, abbreviated as PCC. So these are the drugs which reverse the action of warfarin, and warfarin is only limited to the patients who are having any structural heart disease. Now the drug which is preferred for anticoagulation nowadays are, just a second, yes, these are direct acting oral anticoagulants, DOACs. DOACs are basically a set of drugs which include two major drugs that are direct thrombin inhibitors that include dabigatran, the gatrons. Fine. And the second drug which is included in this set are the factor 10A inhibitors. Fine. These factor 10A inhibitors, these are, I remember it by the BAN family. So I'll write here, it's a mnemonic to remember it, that these are the BAN family. So the drugs are rivaroxaban, edoxaban. These are the direct oral acting drugs. Now the benefit of these drugs is that they have low risk of bleeding as compared to warfarin. So yes, that's why they are mostly used. Fine. But we should always have a reversal agent of the drug if we give increased quantity, or if bleeding start in the patient, then we should know the reversal agent. And the reversal agent for these DOACs, only dabigatran has a reversal agent. I'll write here, and its reversal agent is idrucizumab. What is its reversal agent? Idrucizumab. What this idrucizumab do is that this idrucizumab, what it does is that it binds with the dabigatran and reduce the risk of bleeding. What it does, binds with dabigatran and reduce the risk of bleeding. So it's the reversal agent of dabigatran. This is the whole anticoagulation therapy that we use, and here the whole treatment which is of atrial fibrillation ends. Just a brief overview of the treatment for you to recall is that we have two major problems that the patient is facing is atria, in which blood pooling occurs, thromboembolism is a complication. Secondly, in the ventricles, the rate and rhythm is abnormal, and ectopic firing. For that purpose, individually to control the rate, we use beta blockers or calcium channel blockers or metoprolol succinate in cases when patient has left ventricle systolic dysfunction. To control the rhythm, cardioversion is done. There are two types of cardioversion, electrical and pharmacological. Electrical is preferred over pharmacological cardioversion, but for electrical cardioversion it increases the risk of embolus formation, so we give anticoagulants when we have to start electrical cardioversion 4 weeks before starting the therapy and 3 months after complete cardioversion. Now if we can't wait for this 4 weeks of anticoagulants, we go transesophageal echocardiogram of left atrium and see if there is any thrombus formation within it. And if there is no thrombus formation, then we give IV heparin for 24 hours, and within 24 hours cardioversion can be performed, electrical cardioversion. Antiarrhythmia, other point to maintain the rhythm are the antiarrhythmic drugs. For that we have two options, IV Fecainide and IV amiodarone. If both the cardioversion procedures fail, we go for catheter ablation. And in severe and poorly controlled cases, pace and ablate therapy is used. For anticoagulation, which was the problem the patient was facing, we have two options, warfarin, whose reversal agent is vitamin K, fresh frozen plasma, and prothrombin complex concentrate, but it has increased risk of bleeding, so we'll prefer direct acting oral anticoagulants, which include dabigatran, rivaroxabans, and edoxabans, etc. They have low risk of bleeding, so they are preferred, and their reversal agent of dabigatran is idrucizumab. So this is the whole management of the atrial fibrillation. I hope it will become clear in your mind. If you have any questions, you can ask in the comment section. Please give me your feedback in the comment section, and please like, share and subscribe. Most importantly, share the links so that others can have the benefit, which is main goal of my whole procedure and whole efforts which I'm doing. Thank you so much. Allah Hafiz. Have a nice day.